All right, welcome to the second half of the 10 lectures on fetal echo. Here we go with lecture 6. We start off with a couple chapters on just the technical views, and then we'll move on to 5 chapters that include abnormalities of the pulmonary artery. And as you'll realize over and over again, all of these kind of overlap. So we're going to hit stuff we hit before, and we'll hit stuff that we haven't hit before and may not be clear, but we'll be getting into later. So we'll get it all done. All right, well, the first thing when you're imaging the great vessels, it all gets back to the same thing, which is step 1, determine the fetal situs. I just wanted to put that slide up there to let you know that they keep saying this over and over again. Now, we're going to talk about imaging the great vessels, and we're talking about some specific views that we get. And here they are, just to review. And I put in this right shoulder, left iliac thing, just because a lot of times in these mock exams, they'll ask you how to turn the transducer to get the next view. And a lot of the ones in the heart, you're going to turn to an oblique angle, and they frequently describe it as up from the fetus's left shoulder to the left iliac. So keep that in mind if that's one of the choices. But you'll notice a bunch of these views are axial, just going straight on up the heart, and then some are oblique, and it usually is in that right shoulder to left iliac tilt. All right. Well, actually, no, let's go back. The main thing to see on this slide is that pretty much the bottom view that you can get is the 4-chamber view. It is an axial view because the heart sits flat in the chest, but pretty much the bottom one that you get is the 4-chamber view. And then if you use the apex of the heart as kind of like a hinge, the next view up is not quite axial anymore. The first one, the 4-chamber, was, but then if you use the apex as a hinge and tilt up where the base of the heart is, you go a little bit higher, and where the apex is, you stay where you were, right at the apex, you will end up with this view of the left ventricular outflow tract, also known as the 5-chamber view. In other words, you can see all 4 chambers plus this thing in the middle, which is the left ventricular outflow tract. Now, when you get that view, you can see that the mitral valve and aortic valve are very close to each other, and as we've said millions of times before, the annulus of one kind of blends right into the annulus of the other, so you get this fibrous continuity of the mitral valve to the aortic valve. The other thing you can tell from the picture is that angle between the ascending aorta and the septum. And that is called the septo-aortic angle. So 1, you can tell that there is an angle there. It's not a straight line. And 2, there is septo-aortic continuity, meaning the line of the septum and the line of the ascending aorta are together. There's no gaps in it. Now, at this level, you can see the superior pulmonary veins coming into the left atrium. When you were down at the 4-chamber view, you saw the inferior left and right. You move up slightly to the 5-chamber view or LVOT view, and you can see the superior pulmonary veins. Now, this 5-chamber view that they're looking for, probably in general terms, you can tell that it's best to just come in from the front of the baby. That way you don't get the rib and spine shadows. Here they call it the apical 5-chamber view. They're never really coming quite in from the apex, but the upper left is pretty close. And now, if you had come in exactly at an apical, you would not catch the ascending aorta perpendicularly. So it's actually good that the apex is a little bit off to our left. So again, remember that when the beam is perpendicular to its target, that's when it's best. So if you're looking at the septo-aortic angle and looking for septo-aortic continuity, it'd be nice to come in perpendicular to that. All right. After that, so the first one was 4-chamber. We tilted up a little bit and got the left ventricular outflow tract or 5-chamber view. Now we're going to go up a little bit higher, and we're still basically using that apex as the hinge. And we go up a little bit more, and we've got now the main pulmonary artery, and it splits into two, a right and a left branch pulmonary arteries. And that is called the 3-vessel view. It's also known as the transverse pulmonary trunk view, also known as the 3-vessel view with pulmonary bifurcation. And this is why you can tell that there's always confusion when we're talking about echoes and worksheets of what the 3-vessel view is, what the 3-vessel trachea view is, what are all these things when they all go by several names. Good news is when we get to the 3-vessel trachea view, that seems to be the one view that everybody just calls the 3-vessel trachea view. So there's one view that everybody seems to agree on. These other ones, well, there are all sorts of things being called. But anyway, in the 3-vessel view, the 3 vessels that we see are the main pulmonary artery with its bifurcation, the ascending aorta in cross-section, and then the superior vena cava right where it's about to enter the right atrium. Here's another look at the 3-vessel view. Again, 3-vessel view is pulmonary artery with bifurcation of left and right pulmonary arteries. The ascending aorta, meaning it's just a circle, and then the superior vena cava, also just a circle. Both of those are heading up, and the PA is heading across back towards the descending aorta. Now, I just took a picture of a hockey stick and I took a picture of a candy cane to kind of illustrate what's going on here. So typically, the right ventricle in normal situations is the anterior ventricle. So it's right under the sternum, has a longer way to travel. So it's going to end up at the descending aorta, but has a longer way to travel. So it has a longer curve to it and is described as a hockey stick. The left ventricle, on the other hand, is the more posterior ventricle. So it's a tighter curve, described as a candy cane, and it does go a little bit higher. And basically, that hockey stick really represents the right ventricle, the main pulmonary artery, the ductus arteriosus, and that it ends in the descending aorta. Here's a picture of my hand while I'm putting this lecture together. And I just want to illustrate kind of that relationship, which is my hand is the pulmonary artery and it splits into 2 pulmonary arteries, right and left, and you can see that the ductus continues on straight ahead. That's my middle finger there. It goes straight. It's higher than those 2 other ones, and then it will hook up to the descending aorta. So my middle finger is basically that hockey blade, and then the 2 other ones that are lower are the right and left pulmonary arteries. So if we're in the level where we can see right and left pulmonary arteries, we're not going to see the ductus because it's up there, up top. Now, the next thing you can do is you can move up there, and that is referred to as the transverse view of the arterial duct. Now, suddenly, out of the blue, they're starting to use the term arterial duct because it's a cool way of saying ductus arteriosus. So, ductus arteriosus equals arterial duct. Also known as the three-vessel view with ductal arch. All right, so that's why there's always confusion. Some people submitting this as their three-vessel view, and some people doing the last one as the three-vessel view. Other ones call it the pulmonary bifurcation. But according to Alfred Abu Hamid, the real three-vessel view is that first one that we just showed, which is main pulmonary artery and the bifurcation, but not the ductus arteriosus. Here we are a little bit higher, so not my two lower fingers, my upper middle finger, and that's going to be my hand is the pulmonary artery, the ductus arteriosus is the middle finger, and it joins up with the descending aorta. So in this view, we've got that. We've got still the ascending aorta, so it's a circle, and then we see the SVC, also a circle, still going up. Here's another view of the same thing. Basically, you have pulmonary artery, ductus arteriosus, descending aorta in a straight line from front to back. All right, if you go up a little bit higher, now as I said, the candy cane is a little bit higher than the hockey stick. So if you move up a little bit higher, all you're going to do is find the transverse portion of the candy cane, or the transverse aortic arch. The aortic arch has an ascending, a transverse, and a descending portion. Right now, we're in that axial view that's up high at the top of the mediastinum. Incidentally, the mediastinum is all that stuff in between the two lungs. And the transverse aortic arch is the most superior vessel in that mediastinum. And this is the view where you're going to see the thymus. And there they have it, circled there for you, anterior to the transverse aortic arch. Here we are, we're way up high, so all we see is basically we see the ascending aorta, transverse aortic arch, and descending aorta. Basically, we see all three parts, really. I mean, for the most part, we see the transverse, but you know that it came from the ascending aorta, and you know that it's going to the descending aorta. And then right next to that, you've got your SVC and your trachea. And then here we go. If you now are up at that level, and then you tilt downward toward the left iliac, that means we still have the transverse aortic arch in the picture. But now we've tilted down toward the baby's left iliac, and now you can see the ductus arteriosus, pulmonary artery, and right ventricle. Well, maybe you're a little bit higher than right ventricle. So that's what the three-vessel trachea view is. And you've got your pulmonary artery basically going straight back, and then you have your transverse aortic arch heading back and joining the same place. They both end up in the descending aorta. Right before the transverse aortic arch hooks up to the descending aorta and hooks up to the ductus arteriosus, there's a slight narrowing called the isthmus. And that's what is pointed out on the picture on the right, where it's just slightly narrower, and it's right before it hits the descending aorta. Now here's another picture. Again, this is one of those views that nobody seems to know what it is. In general, we know that this RVOT/short axis is this picture that we're looking at, which is an RVOT, it bifurcates, and then there's a circle of the ascending aorta. Okay, that's kind of what everybody thinks of as the RVOT short axis. Now keep in mind, when we're talking about the short axis, We're not talking about the short axis of the RVOT. Clearly not. We can see the whole length of it right there. What we're doing is we're looking at a short axis view of the heart, or a short axis view of the right ventricle. So in general, whenever we talk about the heart, we're talking about ventricles. So really, this is a short axis view of the right ventricle that shows the right ventricular outflow tract. And this is a really good picture of it. You can see the aorta in cross-section, you can see the SVC, and then you can see the right pulmonary artery. All right, and why don't we see the left pulmonary artery? Well, since the ductus arteriosus is higher, if you've got the ductus and the right pulmonary artery in the same picture, you won't have the left. Remember that picture of my hand? You can't get all three things in the same view. You can only pick two, either the right and left at the bifurcation, or the ductus and the right pulmonary artery in this particular view. All right, so this is the kind of picture that you should just sit and look at for a little while and just feel like you know all the parts that are in it. Knowing that the pulmonary artery is coming from the right ventricle, just under the sternum. It's going through the pulmonary valve, that's labeled, pulmonary artery, ductus arteriosus, and the ascending aorta in that picture. So just, look at that a number of times, look at this one a number of times, and just get familiar with all those pieces. There are not that many of them, so just take a look at that. All right, the next thing we're going to talk about is the LVOT long axis. So we just talked about the short axis of the right ventricle. Now we're talking about the long axis of the left ventricle. So you can see the long axis of the left ventricle, which means from valve to apex. You can see the whole thing. And in that view, you can get a nice view of the left ventricular outflow tract. This is almost the same parasagittal view as the bicaval. It's right nearby that. But in this particular LVOT long axis of the left ventricle, you can see the left ventricular inflow and the left ventricular outflow in the same picture. And as you can tell, they are very close together because of fibrous continuity. All right, here we are with the same exact view, and we've got some color here. The things to look at here is that I've seen from some of the test questions is clearly you know that's the LVOT, so then you can figure out that must be the left ventricle too. And usually, since you know that the mitral and aortic valves are close together, that must be the left atrium right nearby. So yes, so there you see the whole LV inflow and outflow in one picture. One of the ones that they frequently will quiz you on is, look at the picture on the right, and that's the RPA, the right pulmonary artery. We know just tucks under the transverse aortic arch. So the aortic arch curls up like a candy cane, and when you think of, well, what is it a candy cane over? What's this candy cane hooked on? And it is the right pulmonary artery. All right, this view is called the longitudinal aortic arch, or as we call it, the aortic arch. And basically you're seeing that candy cane where it's coming from the more posterior ventricle, not from straight under the sternum. And there you can see a great picture of the three head vessels coming off. They call them head vessels, but they're going to the head and the arms. So the first one you get to is the brachiocephalic artery, which is a combination of the right subclavian artery and the right common carotid artery. Then you get your left common carotid artery, and then lastly you have your left subclavian artery. And then, right after the left subclavian artery, it's slightly narrowed into this area called an isthmus. So just get familiar with what a normal isthmus looks like. It is a narrowing, but it's only a little teeny weeny bit. And it's important is because that is the number one spot of where a coarctation would be. So an abnormal narrowing is exactly where the normal narrowing is. All right. Here's another view, same deal. You've got your isthmus, you've got your transverse aortic arch, ascending aorta, and all the head vessels. All right. Now, there typically are three vessels coming off of this arch. The first is the brachiocephalic artery, also called the brachiocephalic trunk. I only threw that in there because sometimes I've seen it in test questions, and it can get you all confused if you're not aware that the artery and trunk are the same things. It's kind of easier to remember that trunks basically are kind of made of two large branches. So in this case, it's the right subclavian and the right common carotid. And then the other ones are just single arteries, left common carotid and left subclavian artery. So just get familiar with that anatomy. Also, I don't think they pointed it out, but again, the little circle beneath the aortic arch is the right pulmonary artery. Whoa. There we go. All right. Now, this is an important anatomical difference here. Remember, the isthmus is part of the aortic arch, not part of the ductal arch. Now, even though the aortic arch and the ductal arch are next to each other and they're going the same place, they're not the same thing. They're right next to each other. So in this picture, we've got a longitudinal ductal arch, and they've got a little blip that is labeled isthmus. It's not actually part of the arch. It is the thing right before the arch there. So, and since we know that the aortic arch is slightly higher than the ductal arch, that's why the little blip is coming off from above. All right, and lastly, that brings us to the three-vessel trachea view, which gets its own chapter. All right, so here we are, the three-vessel view. This is a nice, simple representation of it, which is you've got that arrowhead that is pointing toward the descending aorta. The descending aorta, as you know, is just slightly to the left of the spine. Here in this diagram, it's a little further off to the left. It's not sitting right on the spine. But in general, the arrowhead is pointing to the descending aorta. So in the three-vessel trachea view, we've got pulmonary artery, ductus arteriosus, and transverse aortic arch converging. You also have the SVC, and you have the trachea. At this level, you have a trachea. Down at lower levels, you don't have a trachea because it's already split into a right and left bronchus. All right, well, how do you get a three-vessel trachea? Here we go. I just threw this in here just to remind you that the first step of getting any image is determining the fetal situs. All right. In this picture, kind of two views of the same thing for the most part. Just get familiar with it. You can see that the thymus is a little less echoic than the surrounding lungs. You can see the trachea there. It's not super obvious, but the thing that sets the trachea off is since the trachea has cartilage rings around it, it'll show with these kind of brighter white echoes surrounding the actual circle there, whereas the SVC doesn't have that. So the cartilage rings make it show up a little bit brighter. All right. Well, in both of these views, we've got color on. And it really kind of demonstrates the fact that the direction it's the same direction. So over on the left one, they're both heading back to the descending aorta, and they're blue because they're moving away from the transducer. Over on the right, they're moving towards the transducer, so they're both red. Now, if you happen to get this exactly perpendicular, you could get one blue, one red, if you've got the arrowhead sitting on its side like that. But for the most part, they're going to be the same color because they're going the same direction. All right, while we're in this view, this is also the view where you would determine whether there is a right-sided aortic arch. Remember, normally in very early embryologic life, there were two aortas. The one on the right regressed, leaving the one on the left. If the one on the left regresses and leaves the one on the right, you've got this right-sided aortic arch. And when they talk about right-sidedness, they're not necessarily talking in reference to what part of the baby it's on, because both the left and right are really on the right side of the baby. What they're talking about is on the right side of the trachea. So trachea is the landmark by which you determine whether it's a right or left-sided aorta. All right. Now, sometimes the right and left aortas persist, and you get a double aortic arch. And when you get a double aortic arch, and you've got a vessel on either side of the trachea, they start together in the left ventricle, and they end together in the descending aorta, they can form a vascular ring. The diagram's a little easier to see. But if you've got a vascular ring, that means the trachea can be compressed between the two aortic arches. Now, rarely you can actually see a right-sided aorta and a right-sided ductus arteriosus, in which case, again, that's determined by their relationship to the trachea. So if the trachea is in the center there, and both the ductus and the aorta on the right side, then you have a right-sided aorta and a right ductus arteriosus. All right. Also in this view, the three-vessel trachea view, is where you might see this fourth vessel, as it's called. So on the opposite side of the SVC and the trachea, you've got this lone vessel sitting over there. You flip on the color, you show that there's actual color. The reason you do that is because you want to make sure it's not just like a bronchus. So you flip on the color, yes, it is a vessel. Your choices are, it's either a persistent left superior vena cava on its way down to curl under the heart by way of the coronary sinus, or it is a vertical vein, meaning the pulmonary veins go into a confluence, and then the confluence goes by way of a vertical vein up to the, it can go a number of places, but including the superior vena cava. All right, while we're up here, we can also talk about the aberrant right subclavian artery. Now, normally, the right subclavian artery came off of that first branch, brachiocephalic artery. But sometimes it doesn't. It doesn't come off that. It comes off later as the last vessel. So instead of being on the branch first, it's the branch last. And you can see it up there sneaking behind the trachea. So you see the trachea, and then there's this other blood vessel there going behind it on its way to the baby's right arm. All right, we got to talk about the thymus. So the thymus is a little more hypoechoic than the lung. If you do a ratio of the AP dimension of the thymus compared to the AP dimension of the thorax, it's about 0.44. So just remember, it's a little bit less than half. So up at the 3-vessel trachea view, that stuff between the vessels and the sternum is thymus. Now, you can have an absent thymus, you can have an undergrown, hypoplastic thymus, but generally, anytime the ratio is less than the normal, 0.44, be thinking there's a problem with the thymus. Very frequently, the ratio is less than 0.3 when you're talking about 22q11 deletion, or DeGeorge syndrome, or velocardiofacial syndrome. All right, so as you look at those pictures, you can see that, let's say the picture in the center, the absent thymus, you can see that the pulmonary artery basically is arising, it's almost touching the sternum in the front. Normally, there's that little gray area in between the pulmonary artery and the front of the chest, and that's the thymus. But in these cases, it's right up there against the front of the chest. So if you see that, think, oh, thymus is missing. All right, now we're going to move up even higher. So now we're way up at the top, and when you're way up at the top, you catch the left brachiocephalic vein. So the brachiocephalic vein has the left jugular and the left subclavian vein. They join together into the brachiocephalic vein, and they head across to join the SVC. So while it's doing that, making its transverse course, it provides the posterior boundary of the thymus. So this is important for things like persistent SVC. It won't be there. And it's also important when we get into conotruncal abnormalities that we may see an abnormal course to that. All right, well, that's a discussion of the views for the great vessels. And now what we're going to do is we're going to start doing some specific pulmonary artery abnormalities. All right, let's start with pulmonary stenosis. Well, when you have pulmonary stenosis, this valve has, the different leaflets. And so the leaflets are the little flaps, and the little commissures are basically the lines between them, where they join when they're closed. And what happens with pulmonary stenosis is these commissures are partially fused. They don't open all the way. Now, normally leaflets do open all the way, and when you look in systole, they disappear. They flatten up against the walls of the vessel, and you can't see them. But if you have pulmonary stenosis, the leaves don't open all the way, and even in systole, you can see where the pulmonary valve is. Now, whenever we're talking about pulmonary stenosis or pulmonary valve narrowing, it's usually at the valve level, but it can be below it or above it. Pulmonary stenosis is actually kind of easy to miss in the first half of pregnancy because it can be progressive. So very early on, it may not be showing much in the way of ultrasound findings. But over time, the narrowing progresses, and the things that the narrowing causes in terms of ultrasound findings, they start to become a little more obvious. All right, let's talk about what happens as it progresses. So the commissures are slightly fused. They don't open up all the way, and they don't close all the way, and you can see them. What happens? Well, that narrow valve has a normal right ventricular muscle behind it pushing blood through it. So if you're pushing blood through a tiny hose, like putting your finger on the hose and suddenly it goes faster and shoots farther, that's what's going on here. So early on, the narrowing just causes an increase in velocity through that narrow valve. And you can see that in the color Dopplers over there. It's a higher velocity and it's turbulent flow. Well, the velocities increase. Typically, they go over 100 meters per or 100 centimeters per second. And very frequently, they get even higher than that, depending on the grade of obstruction. So when you've got moderate and severe, we're talking up in the 200 plus range. Well, the next thing that you're going to start to see is something called post-stenotic dilatation, meaning that right after the obstruction, there is a dilatation of the pulmonary artery. So this high velocity that's shooting through there, and it's very turbulent, causes the pulmonary artery to dilate just beyond the valve. All right. Now, this valve, the commissures are fusing, doesn't open all the way, but it also doesn't close all the way either. So you start getting this pulmonary regurg. The blood's supposed to move forward, and as it slides back, it closes the valves and stops. It doesn't go back into the ventricle. But if the process has progressed and the valves are not closing very well, then you will see pulmonary regurgitation. So the Doppler at the right shows high velocity in both directions, basically. All right, the next thing that's going to happen is over time, the right ventricle has been working really hard to push past this narrow valve, and the myocardium starts to thicken. The pressure is a lot higher in that right ventricle and may cause the septum to bulge toward the left. So we're getting a thicker wall, we're getting a septum that's bulging toward the left because of the high pressure in the right. And then, in severe cases, the right ventricle lumen doesn't grow. Basically, we're going to see exaggerated forms of this later, but the growth of a ventricle depends on blood flow through it. It needs inflow and it needs outflow. And if it doesn't have very much, it never really grows, just because the amount of volume that's filling up the ventricle each time isn't as much. All right. The next thing that happens, the right ventricle is pushing so hard that the blood goes the wrong way through the tricuspid valve. Normally, the right ventricle contracts and it just pushes hard enough just to close the tricuspid valve. But now the ventricle is pushing so hard to get through the pulmonary valve, it actually blows the tricuspid backwards too, and you get tricuspid regurgitation. Now, it's not like the tricuspid just flies in the other direction. It flies a little bit, and there's a little tiny gap between the leaflets. So if you've got the right ventricle pushing through a tiny gap in the tricuspid, the velocity is very high. All right. Pulmonary stenosis. It can be an isolated finding, but the recurring theme in this whole echo course is that although things can be isolated, they very frequently come with other stuff, other structural defects, other causes, like things like chromosomes and genetics and so forth. But when it comes to pulmonary stenosis, it's frequently with other things. Obviously, tetralogy of Fallot is one of them, considering that's one of the 4 things for tetralogy of Fallot. And then another very important association whenever you're thinking about pulmonary stenosis is Noonan syndrome. So certainly the association that should jump out at you is if you see tricuspid regurgitation and you have an increased nuchal translucency in the first trimester, think of Noonan syndrome. Incidentally, Down syndrome has increased nuchal translucency and tricuspid regurgitation also. But Noonan, because of the pulmonary stenosis, is going to have that combination potentially. All right. Now, in general, a lot of these things have things that grade the severity of them so that the patient can be counseled about what's going on. The surgeons have an idea of what the repair is going to be, whether the repair is going to be attempted at all, and things like that. So, in general, the things that kind of tip you off in general to pulmonary stenosis are the post-stenotic dilatation of the pulmonary artery. That's usually the one that tips people off. Just because, for the most part, people are not doing pulmonary artery Dopplers for peak velocities unless they're doing an echo, so they're not going to pick it up that way. The way they're going to pick it up is that post-stenotic dilatation. And basically, once you see that, then you do look for the velocity, and if you see that it's over 100, now you're very suspicious for pulmonary stenosis. So, if it's just an increased velocity, we say that's mild pulmonary stenosis. If it's super high, meaning over 200 centimeters per second, now you've got the moderate and severe. And then the difference between moderate and severe is when you're so advanced that valves are starting to fail. The pulmonary is failing and blood's going backwards, and the tricuspid is failing and blood's going backwards. The bad prognostic signs. Well, that means you look at the ultrasound and you're saying, ooh, wow, this is not good. And they have to be counseled about that. So the things that we're looking for that would be bad prognostic signs is retrograde flow in the ductus arteriosus. All right, normally there is antegrade flow because blood comes out the pulmonary artery, goes through the pulmonary valve, branches into right and left, and then heads on as the ductus arteriosus. Now, if that's not really happening, that kind of gives the impression that the right ventricle isn't pumping hard anymore. Now you went from super high velocity to now it's actually going backwards. So retrograde flow in the ductus arteriosus, and then certainly a small right ventricle. If your ventricle is not growing, well, at 40 weeks, it's not going to be a 40-week ventricle. It's going to be a tiny ventricle and may not be usable at all. And the surgeons need to know that because they want to try to figure out and plan for a biventricular repair or univentricular repair, meaning basically you've got a heart that has normally two ventricles, two pumps that sit side by side. If the surgeons know that there's only one pump, the other pump doesn't work anymore, they need to rearrange the plumbing to use only one ventricle to do all the work. And they will look at these things like the size of the right ventricle and the retrograde flood in the ductus to figure that out. All right, our next entity is pulmonary atresia with intact ventricular septum. So sometimes abnormalities happen together enough that they get their own title. So pulmonary atresia happens often enough with an intact ventricular septum that we use that to differentiate it from other types of pulmonary atresia. So again, pulmonary stenosis is a narrowing and a pulmonary atresia is a lack of formation. And with pulmonary atresia, there is no communication between the right ventricle and the pulmonary circulation. The commissures are completely fused, so the blood going into the right ventricle has to go somewhere, and we just said that it can't go out the pulmonary artery. So where does it go? Well, one choice is it goes backwards through the tricuspid valve, tricuspid regurgitation. The other thing that's kind of cool is that the right ventricle gets such high pressure that it kind of forces open these little tunnels within the myocardium. And they call them ventriculo-coronary arterial communications, meaning the blood in the chamber, instead of going out the pulmonary artery like it's supposed to, gets forced out through little channels in the wall into the coronary arteries and goes backwards that way. But in either case, the right ventricle is small. And you can see over at this diagram, you've got a very small chamber or lumen, a very thick wall, and in one case, there are these ventricular-coronary artery communications, meaning they kind of blast through the wall, hook up to the ventricle, and they get to the aorta that route. Again, for a ventricle to grow, there must be flow through it. So, if it's not growing, there must be a problem, either with the flow in or the flow out. And with pulmonary atresia with intact ventricular septum, the problem is initially flow out. Can't get out of the ventricle. How do we suspect it? Well, typically there's this small hypokinetic right ventricle. Hypokinetic meaning the fractional shortening is very low. It's not squeezing very hard at all, and it's hypoplastic. It's not very big. Here's some other pictures just to give you an idea of the different looks. You've got a right ventricle, but the actual chamber size or lumen is very tiny. The wall is very thick. And in the three-vessel view, I think this is the pulmonary bifurcation view, or it may actually be the RVOT short axis. But in either case, that's the view where you are at the level of the aortic valve and pulmonary valve. And you can see that there's a big discrepancy between the pulmonary and the aorta. On color Doppler, sometimes you'll simply see that as just one flash of color on the left side and nothing going on the right, or as in the picture in the far right there, a little blip goes in there into the right ventricle. So yes, there is some movement, but not very much. All right. As long as the ventricle's working, you can have tricuspid regurgitation. You won't have tricuspid regurgitation if the heart isn't pushing very hard, because basically it has to push it backwards through the tricuspid through a little tiny gap. So as long as the right ventricle is working, you can get this tricuspid regurgitation. The other thing you may notice is that the inflow, the E and A wave of the inflow are disturbed and they become monophasic. Anytime you have a stiff ventricle, you're probably going to have a monophasic flow, meaning nothing flowed in all by itself in early diastole. It had to be jammed in there by the atrial kick. All right. Ventricular coronary arterial connections. As we said, the blood's got to go somewhere. It can go backwards through the tricuspid, or it can go out these little channels and join up with the coronary arteries. So most of it goes back through the tricuspid valve, or regurgitation. If the pressure just keeps getting higher and higher, it pushes open these embryologic channels and they stay open. So if you've got a very small right ventricle and you don't happen to see any regurgitation, look carefully for these ventricular coronary arterial connections, or VCACs. All right, what does the three-vessel trachea look like here? Well, instead of both parts of the arrowhead going the same direction, there is no forward flow in the pulmonary artery. In fact, what you have is retrograde flow, meaning the blood comes out the left ventricle, goes up the ascending aorta, goes across the transverse, and then right about there, it goes back into the ductus arteriosus backwards and then fills the branch pulmonary arteries. So the lungs get their artery blood flow backwards through the ductus arteriosus. right, here's some poor prognostic findings for pulmonary atresia within tract ventricular septum that you can look at your leisure. But basically, among the worst things are small ventricles that don't contract very much. All right, now we're going to talk about tetralogy of Fallot. And although we have this idea that it's just kind of one thing, it includes several different looks to it. And we'll start with the classic tetralogy of Fallot, which is defined as a malalignment ventricular septal defect. The aortic root overrides the ventricular septal defect. And then here's the variable part for the most part. There are varying degrees of right ventricular outflow tract obstruction. So they can be valvular, they can be infundibular. Infundibulum, just to digress here, an infundibulum is a funnel. So that area of the right ventricle that's heading toward the pulmonary artery is the infundibulum. It's kind of like a cone of muscle that ends up pointing to the pulmonary artery. So you can have narrowing there. That's where your obstruction can be, or more likely at the valvular level, pulmonary valve. And then the last thing of tetralogy of Fallot is right ventricular hypertrophy. But generally, it hasn't really developed in fetal life because the obstruction isn't that severe usually. And so you don't see it in fetal life, it develops later on. So usually the fetal things are the first three. And the embryologic explanation of what happened is basically the conal septum is leftwardly deviated and you have an incomplete rotation of the heart vessels. All right, so as I said, tetralogy of Fallot isn't really just one thing, one entity. It's kind of a spectrum. And let's spend a little moment here. All right, so tetralogy of Fallot with varying degrees of pulmonary stenosis, meaning the right ventricular outflow tract is a narrowing of the aorta. It can be, of the pulmonary valve, sorry. So narrowing of the pulmonary valve is the main thing for classic tetralogy of Fallot, and this counts for 80% of them. But you can also have tetralogy of Fallot with pulmonary atresia. So you still have your malalignment VSD, you still have your overriding aorta, but now the right ventricular outflow tract is complete and it's pulmonary atresia. So we talked about pulmonary atresia with an intact septum. Now we're talking about pulmonary atresia with a ventricular septal defect. This is actually part of the tetralogy group. And then lastly, you can have tetralogy of Fallot with an absent pulmonary valve, meaning you still have your overriding aorta, you still have your malalignment VSD, but now what you've got is this absent pulmonary valve. And as we'll talk about in just a little bit, the obstruction component is because there's frequently no ductus arteriosus at all. All right, so what do you see on tetralogy of Fallot at the four-chamber view? Well, actually, usually not much. Probably the one thing that you'll see is left axis deviation, which we see with a lot of heart defects. At the five-chamber view, or left ventricular outflow tract view, what you'll see is the aorta has shifted over toward the right and is straddling the septum. So no longer do you have that normal aortic septum angle. You've got an overriding aorta and you have a lack of that angle. It's a little more parallel than angled. Just another couple things to look at here. We've got the septo-aortic angle intact on the left, and over on the right, we have an overriding aorta and a parallel aorta and septum. Now, moving on to the three-vessel view, which is the one that has the pulmonary bifurcation. Well, the thing you're going to see is a narrowed pulmonary artery and a widened aorta. So disproportion at that level. The other thing that you may see, particularly in the first trimester, because you're using color to figure it out, is that the the outflow in the aorta comes from both ventricles. And it comes from both ventricles because it's overriding, it's straddling the septum, so blood's coming out and going through the aorta. The reason it doesn't go through the pulmonary artery very much is because it's narrow, it's obstructed. So this Y sign is a color Doppler finding. All right, here's a couple more examples showing the disproportion between the pulmonary artery and the aorta. In the three-vessel view, what you'll see typically is very often, since it is pulmonary stenosis, you'll still have antegrade flow, but the pulmonary artery typically is smaller and less contributory to the flow. All right. Well, velocities for the most part aren't necessarily increased. Probably it's more important to look at the size. So yeah, you're looking at pulmonary artery size and aortic size. Now, again, just to make everything confusing, very frequently these diagnoses are not isolated. So just because it has tetralogy of Fallot and you can remember the 4 things or the 3 fetal things, be prepared that there are often other abnormalities too. And one of the common ones is a right-sided aortic arch. So even though you start scanning and you have this suspicion there's an overriding aortic arch, you have a hard time finding the pulmonary artery flow, and you're thinking tetralogy, again, it all gets back to the same thing, which is, okay, well, you can be suspicious of that, but you still then have to do a very systematic analysis of everything, in which case you'll be finding the tracheal position in relationship to the aorta. So again, the associated things with tetralogy of Fallot, it doesn't seem to come by itself very often, but right-sided aortic arch and absent ductus arteriosus. In terms of etiologies, trisomies are involved 30% of the time, and 10 to 15% of the time you have the 22q deletion. Here's a bunch of other ones that you can see that are associated with. It just kind of tells you, oh yeah, there's sometimes other stuff. All right. So typically, the thing that tips you off is there's a VSD and an overriding great artery. And you have to figure out, well, what's going on? Is it pulmonary artery? Is it an aorta? What is it? And you have to figure that out. And then run through the differential diagnosis. All right. Let's talk about pulmonary atresia with VSD. They used to call it severe tetralogy of Fallot. So basically, remember you've got overriding aorta, septal defect. We don't have RV hypertrophy yet, but we do have RV OT obstruction, and in this case, it's complete. All right. So sometimes you'll hear severe tetralogy of Fallot, sometimes you'll hear tetralogy of Fallot with pulmonary atresia. The main difference between pulmonary atresia with a VSD the main difference between pulmonary atresia with VSD and classic tetralogy of Fallot is really the degree of obstruction. With tetralogy of Fallot, there is right ventricular outflow obstruction. With pulmonary atresia as the obstruction, it's complete. All right, well, if the blood can't get out of the right ventricle, how does any blood get to the lungs? Well, these collaterals form. These little vessels just pop out of the descending aorta and start feeding the lungs. And they're called major aortopulmonary arterial collaterals. So you've got a connection between the aorta and the lungs by way of these collaterals. And the way you'll see it on ultrasound there is just like the color picture shows, which is some vessel coming off the descending aorta and going right back to the lungs. All right, pulmonary atresia with ventricular septal defect. The four-chamber view is usually normal, unless there's a huge VSD. And very commonly, the thing you'll see is a left axis deviation. In the five-chamber view, it's pretty much the same as the classic tetralogy of flow, but since no blood goes through the pulmonary artery, that means more has to go through the aorta. So the aorta is considerably bigger with PA with VSD. All right, in the three-vessel view, the one that shows the bifurcation, again, the main difference is way more disproportion between the pulmonary artery and the aorta. So it kind of makes sense. If you have a narrow pulmonary artery, there's not going to be much flow. It'll be kind of small. If you have no flow, it's going to be way smaller. All right. Now, once you suspect this pulmonary atresia with a VSD, look for these major aortopulmonary arterial communications. Look for them in the low velocity settings and look for them coming off of the descending aorta. How to use them for prognosis, not too clear, it's kind of debatable, but here's two more pictures of the same thing. And again, very few of these heart defects are all by themselves. There's something going on. And the structural things that tend to go along with this is an absent ductus arteriosus, a right-sided aortic arch, and often a secundum atrial septal defect, which we'll talk about more later. It happens to be higher in maternal diabetes, higher incidence of chromosome problems, and 22q deletion is very high, 20 to 60%. And then lastly, we're going to talk about the absent pulmonary valve syndrome. And basically what it is it's a type of tetralogy of Fallot, meaning aortic override, ventricular septal defect, right ventricular outflow tract. And basically, you have no ductus arteriosus, and your pulmonary valve doesn't function very well. So basically, the right ventricle pumps. Some of it goes out the aorta, some of it goes through the pulmonary valve into the pulmonary artery, but then it has no place to go, so it just keeps banging in there and blowing up the right and left pulmonary arteries. So what you'll see is very dilated right and left pulmonary arteries, and you will not be able to demonstrate a ductus arteriosus. So in the four-chamber view, again, you may see left axis deviation like we do here. And then at the three-vessel view, where you see the bifurcation, you have a dilated pulmonary, you have very dilated right and left pulmonary arteries. And then the thing you see on color is this to and fro movement. It moves forward into the pulmonary artery, but then it slides right back into the ventricle because there's no valve to keep it from doing that. So you can see the waveform has this very high volume to and fro movement in the pulmonary artery through the valve. Here's some more pictures of massive dilatation of the pulmonary artery. And you can see this very early on as well, this to and fro movement, even in the first trimester. And again, you've got associations with other structural things, right-sided aortic arch, absent ductus arteriosus, and 22q. The other thing you can see in absent pulmonary valve syndrome is bronchomalacia, meaning softening of the bronchi. They're compressed by these massive pulmonary arteries, and these babies can have difficulty breathing. Now, of all the things that we've talked about, absent pulmonary valve syndrome is at the bad end of the spectrum. It's mostly due to heart failure of this right ventricle having to work so far, but also because of this bronchomalacia, that the bronchi were injured by this compression. All right. So whenever you see a ventricular septal defect in an overriding aorta, we want to know where it's coming from, and whoops, sorry. So you see the ventricular septal defect in an overriding great artery. I'm not sure what it is, but so you look carefully for a pulmonary artery coming from the right ventricle. And then if you see it, then you figure out whether it's small, medium, or normal. And if it's normal, well, then that's not tetralogy of Fallot, that's just a malalignment VSD. If you have a small pulmonary artery, or moderate size, that is tetralogy of Fallot. And if it's extremely small or absent, you can't demonstrate it at all, any flow, that's pulmonary atresia with a VSD. If the pulmonary artery doesn't arise from the right ventricle, it arises from an overriding aorta, that's a truncus arteriosus, and we'll talk about that in the future. All right. So the key things for absent pulmonary valve syndrome is the aorta is normal size. It's not bigger. Remember all the other ones, most of the flow was directed to the aorta and it was bigger. The ductus arteriosus is usually absent, and you've got a big dilated right ventricle from all this extra work it has to do, because with this to and fro movement, it pumped a bunch of blood, and a bunch of blood came right back and filled up the right ventricle. So it's already having to pump blood that it's already pumped before, and that's what puts it into failure. And that's all we'll discuss today.